Good morning, everyone. My name is Almodaweb, and it's a pleasure to be amongst all of you here today. I am currently a pediatric resident working in the UAE, and today I'm going to be presenting to you an interesting case of a central line associated bloodstream infection with a very rare organism. I hope you find this interesting too. So I'm going to talk about the case itself, but before that I'll go briefly about central line associated bloodstream infections, the epidemiology, pathogenesis, and most common organisms that lead to CLABSI. I'll talk as well about the case presentation in details and how we approached this case and management, and how we approached the challenging clinical aspects we faced in our case. This is the link of the article. I'm going to leave it for you for reference. If any one of you would like to read it or have a look at it, it's a free access article that you can find on PubMed. So to begin with, what is a central line? So a central line can be seen as a thin flexible tube or as a catheter that has a tip that lies in the proximal 1/3, either of the superior vena cava, the right atrium, or the inferior vena cava, which is primarily placed into a large vein above the heart. It can be placed peripherally or into three main blood vessels, which are the blood vessels I mentioned, and it is essential in pediatrics for multiple reasons. Finding peripheral access in children has its own challenges. However, there are multiple other indications of having central lines. Those include, but are not limited to, administering nutrition, administering drugs, especially in patients that require enteral malnutrition, or patients that have malignancies and require chemotherapy, or patients that require frequent blood sampling or require a long duration of treatment. Moving on to central line bloodstream infections, it is primarily a clinical definition. A CLABSI can be defined as a laboratory confirmed bloodstream infection, not related to an infection at another site, which is important because it has to be from the central line itself, which should have been placed at least more than 48 hours before. Most cases are preventable with proper aseptic techniques, regular surveillance, auditing, and management strategies. Central line associated bloodstream infections are considered a major cause of prolonged hospital stay and are a major cause of increased mortality and morbidity in the healthcare. What are the risk factors of having those infections? So the longer the duration the central line is there, the higher the risk of having a central line infection. A younger patient age, the use of an extensive guide wire during repositioning or replacement, and specific techniques of handling and maintenance of the indwelling catheter have all been associated with having a higher risk of infection. Others include TPN, chronic hemodialysis, malignancies, which are basically indications of having the central line itself. The central lines that are mainly at risk of CLABSIs are tunneled catheters. Tunneled catheters have a cuff that causes a fibrotic reaction around the cuff. Sorry, it's non-tunneled catheters. It's because tunneled catheters have a cuff that causes a fibrotic reaction around the catheter. This leads to or creates a barrier that prevents bacterial migration. The absence of a tunnel in a non-tunneled catheter makes it more susceptible or more prone to central line associated bloodstream infections. The pathogenesis involves 3 to 4 mechanisms, but mainly the primary mechanism is migration of the skin organisms at the site of the insertion of the catheter into the cutaneous catheter tract and along the surface of the catheter with colonization of the tip of the catheter. That's the most common route or most common mechanism for the bacteria to migrate from the central line. Others can be direct contamination, and less commonly it might be hematogenous as well. In other rare cases, it could be the infusate itself that's contaminated, leading to the. Moving on to the epidemiology, the most common microorganisms are coagulase negative staphylococci, which occur in around 38% of CLABSI, Enterococci, Staphylococcus aureus, amongst other infections as well, can be causes of CLABSI. Fungal infections as well can, specifically candidial infections, account for around 12% of. Moving on finally to the case presentation itself. The case was about a 6-month-old boy who has a known case of short gut syndrome secondary to short bowel, secondary to necrotizing enterocolitis that he developed while he was a neonate, which rendered him to be completely dependent on TPN. He developed a fever for the duration of 1 day. The patient was receiving the TPN 3 to 4 times a day through the central line, along with a G-tube as well that was in place to wean the TPN. The Boroviac line was placed 3 months back, and he was on home total parenteral nutrition. The fever was high grade and not associated with any other symptoms, and there wasn't any specific focus of infection. For that, the child was admitted and investigated with a full septic workup, which included CBC, CRP, calcitonin, amongst other inflammatory markers, and an electrolyte panel. The total white cell count for the patient was 5.14, with neutrophilia of 80%. CRP was only slightly elevated, it was 21, and procalcitonin was approximately in the normal range. The electrolyte panel only revealed mild hyponatremia with a sodium of 133. The respiratory PCR panel and COVID PCR were both negative, just to rule out other causes of infection. However, we couldn't find any. Therefore, the main suspicion was that this could be a central line infection which need to be treated empirically. We opted to use vancomycin to cover for gram-positive organisms, mainly MRSA, and meropenem to cover for gram-negative organism, and mainly ESBL. After that, we also collected blood cultures, central and peripheral blood cultures. The gram stain was positive for gram-positive cocci individually and in short chains. After inoculation into the appropriate media, we found that there was an isolate identified as Kocuria varians with a 99% probability. Antibiotic susceptibility was also done for this patient, and we found that the organism was penicillin resistant. However, it was sensitive to vancomycin, clindamycin, and gentamicin. Therefore, we only continued the vancomycin, and meropenem was stopped at a later stage once the Kocuria was identified. As the bloodstream infection with Kocuria are rare and there were no specific guidelines for the treatment of Kocuria, and because of the susceptibility testing, we continued with the vancomycin specifically. Repeat blood cultures after 48 hours and grew the first Kocuria from the CVC, but following that there was no growth from the peripheral blood. Since initiating the antibiotics, the child remained afebrile, hemodynamically stable, and was actually asymptomatic. He was also doing well and clinically improving. Therefore, we opted to continue with the same antibiotics. We also did an echocardiogram as well as an abdominal ultrasound, and they did not reveal any variations or clots. Like I said, the subsequent blood cultures were negative, and we continued the vancomycin for a total of 14 days. After that, the child was afebrile throughout his hospital stay, and the main point was that we also managed to salvage his CVC. So just as a discussion, I'll go briefly through the Kocuria organism specifically and what was the clinical challenge here in this case, which was basically the challenge of keeping the central line versus taking it out, which would have been the easy option. So regarding the Kocuria species, they are uncommon pathogenic organisms in humans. There are around 25 species of Kocuria identified up to date, and those include Kocuria varians, Kocuria cristania, Kocuria marina, amongst Kocuria rosacea, and other Kocuria organisms as well. They are catalase positive and coagulase negative gram-positive cocci, seen mainly in clusters. However, they, like in our case, they can be found individually as well. They're rarely pathogenic organisms in humans, but they can be found in the normal skin flora and in the oral cavity as well, and they can be found in other animals as well. When we went back to the literature of this case, we found that cases with Kocuria are negative, are very limited in the literature. They have been responsible for infections most commonly in immunocompromised patients. However, the amount of articles we found were very limited. Kocuria cristania was first described in 1974. Incidentally, it has been reported to cause other catheter-related epidemias as well. The challenging part was that there was no specific treatment guidelines for the management of Kocuria, as the numbers of cases were limited. However, our treatment was guided mainly by the susceptibility testing. However, of those cases that were present in the literature, most of them have been found to be resistant to ampicillin and erythromycin. Susceptibility was highest to vancomycin, linezolid, and teicoplanin, which are all glycopeptides, and therefore this tempted us to continue with the vancomycin, especially that the patient was clinically improving, along as high susceptibility to cefotaxime and meropenem as well. Monotherapy with vancomycin, oxacillin, and peptido, or combination therapy with two glycopeptides such as teicoplanin and vancomycin, or vancomycin and meropenem have been successful before, but because our patient was clinically improving and the susceptibility testing was like the bacteria itself was susceptible to vancomycin, we opted to only continue with a monotherapy of vancomycin. Regarding CLABSIs in general, it is recommended that empiric treatment is started to cover both gram-positive and gram-negative organisms while waiting for the blood cultures, and not when the results of the blood cultures are positive. For gram-positive, we can cover with vancomycin, specifically if MRSA is prevalent. For gram-negative organisms, we can use ceftriaxone, or we can even use meropenem, such as our case when we wanted to cover for ESBL. Once the antimicrobial susceptibility results are available, de-escalation to specific therapy can be done, which is exactly what we did in our case when we opted to. Those are present, it's basically better to remove the line because it's unlikely that the patient will respond to the antibiotics. In our case, the first and second cultures grew Kocuria variants, but the subsequent blood cultures were negative. Just to summarize, we went with vancomycin for 14 days, and we succeeded in clearing a CDC-associated bacteremia. It was important to salvage the central line for this patient because we wanted to continue giving him total parenteral nutrition, and it is vital for his growth, especially that he's a known case of short bowel syndrome. To the best of our knowledge, this patient represents a very rare case of catheter-related bacteremia caused by a rare organism with Kocuria variants, and it's the first one actually that was treated with antibiotics only and without removal of the catheter. It was vitally important for the patient to rescue his central line in this case, especially that he was a patient with severe malnutrition for the causes we mentioned already. Those are my references. You can also find the article, the link of the article in the beginning of the lecture for reference. I hope you enjoyed this lecture, and I'd be happy to answer any questions you have. Thank you so much.